Hi, this is Junaid with Acute Ischemic Stroke 2019 Guidelines Review Series. In this, we're going to continue with the prior lecture and discuss pre-hospital systems, and this time we're going to also concentrate on Telestroke. I'm really grateful for VMed for putting this education series and supporting me to produce this for everyone and not just their clients. So this is what we discussed, the outline, and is divided into 6. We're still on the chapter 1 or the part 1 of the guidelines, and in this particular lecture we're going to discuss 1.4 to 1.9 hospital stroke capabilities and all the way stroke systems and quality improvement process. So let's get into it. Then one of the things that they are actually asking is that there should be certification of stroke centers, and that certification should matter in the sense that this actually identifies for the public and the community at large that what are the capabilities of that particular hospital that is taking care of your stroke patient. Again, the level of evidence is not there, but in my opinion, again, as a public health policy, as a concern for how to manage this stroke on a public basis, this is important to actually have identification by an authority external to that hospital to know what are the capabilities of that particular hospital system. The most famous one is Joint Commission, but there's of course other different bodies that also identify and certify different hospitals according to their capabilities. The other big one is DNV, and that's also another certifying body for stroke systems and hospitals. So I'm going to concentrate on TJC because that's one of the biggest ones that actually does it. But again, DNV is not that different as far as compared to TJC. So it's a little semantic different at best, in my opinion. TJC identifies 4 different forms of hospitals. The lowest form is the acute stroke ready hospital, in which there's the ER that has a specific process that has been identified, and then potentially can push TPA and then send to the patient. Primary stroke centers are the one that is by definition are TPA ready, and they actually have some capabilities of CT angiogram, and then potentially have a good, more robust transportation system to either a thrombectomy capable center or a comprehensive stroke center. What's the distinction between a thrombectomy capable center and a comprehensive stroke center is twofold. Number one is 24/7 availability of neurointerventionist and a neuro ICU. A thrombectomy capable center would be someone who is in the rural area, and then by the time you get to the comprehensive stroke center, you have a person who's on call for a limited period of time, and they can do the thrombectomy and then move the patient to a comprehensive stroke center. And at times when that's not available, then the patient can actually go directly to the comprehensive stroke center. I think that's a good thing, in my opinion, providing that, especially in some rural areas, if there's not full coverage, at least there's some coverage. And therefore, this particular designation was created by the TJC to provide more options for thrombectomy as the evidence grew to support it more and more. So as far as hospital stroke teams are concerned, the word is the team. What they're trying to do in this particular recommendation is that you should have an organized protocol in which all the stroke care, especially the acute portion of stroke care, because right now we're still in the pre-hospital and stroke teams members concerned, is actually organized, and there's standardized, and there's a protocol that is actually written down and available to all the team members. There should be a proper designation of the roles, and there should be proper designation of what their particular job is, especially when an acute stroke is done. So again, those two things are again more about organization. Again, the level of evidence is not there, but at the end of the day, the class of recommendation is high. The third one is very important, is there should be a multi-component quality improvement process. And that's the whole idea. When you have an organized team, they know what their job is, then the data is collected accordingly, and then you can act on that data in a quality improvement process. Because whenever you're talking about systems of care like stroke, MI, and STEMI, etc., the quality of care is extremely important and does matter, and there has been tons of evidence around it, all the way from ICU to stroke, of course, and saying that that quality improvement, when the data is collected in the right way and engaged, then it makes a difference. So there should be stroke systems of care that should be developed with proper organization protocols and everything. And then this is the key issue: establishing and monitoring target time goals. And this is what the big push behind the Get With The guidelines was, that we are getting all the data and that the target times are appropriately organized and retrieved. And therefore, when you actually look at the data afterwards, we can actually see that. And that's the term afterwards. The issue really becomes is that, as in any code, and if you are, since I'm a neurocritical care and we do, code blues and CPRs and everything, the biggest thing we do is we actually have a huddle right after the code. And the right behind after the code was that to provide feedback to the whole team, hey, you did this right, you did this wrong, etc. And so that we are very much more ready for the next code. And we should treat code strokes as code strokes. And the idea is that you should get that feedback. Unfortunately, in my opinion, that feedback is lost, and that there should be more real-time feedback as compared to non-real-time feedback. So it's very important, in my opinion, to at least get with that feedback within 24 to 48 hours. And I personally saw the difference when I asked for that data within 24 hours. Unfortunately, it wasn't available on the weekends, but at the end of the day, it was the first step. And then we were able to identify, where the problems were. And then people were really appreciative because they wanted that feedback too. The nurses wanted that feedback. Physicians wanted that feedback. Hey, if I did not call back in the right time, or if I was talking and missed another call, there should be a way. Where's the backup? How are we going to do that? There is multiple people that are involved, and therefore that feedback, in my opinion, should be real time. Well, how does this all translate into the hospital? And that's one of the things that we discuss. So TJC has created Target Stroke, and there's phase 2 and phase 3. And these are honor rolls that are actually awards that are given to the hospitals. I'm not sure if there's actually a real monetary value attached to it, but there is clearly, if you are actually on a roll, there would definitely be a difference. For example, you're going to be recognized by U.S. News and World Report. If Medicare and Medicaid is actually looking at giving grants, they're definitely going to take that into account. So it's not for unused. There is definitely monetary value attached to it. I'm not sure if it's a direct value or if it's an indirect award situation that is going to help in the future grants and everything. So there are different phases that were discussed, and that now we're actually moving from phase 2 to phase 3, and then there are different levels. So there's roller elite plus, and role advanced therapy. Everyone is actually trying to decrease the door to needle time, and door to needle time is the key issue. And then we were in phase 2, and these are phases that we're preparing all the hospitals slowly and surely to get to the level, and then quite a bit improvement has been noted in the last 10 years because of these award programs. So the door to needle time in phase 3 is going to go to 45 minutes for 75%, and door to needle time for to get to 30 minutes in about 50% of the patients. And that's where everyone should actually try to go. But of course, it comes to a significant amount of resource utilization, and therefore it may not be capable in some rural areas, but at least at comprehensive stroke centers, I think every comprehensive stroke center should achieve Rule Elite Plus. And now the advanced therapy is coming into a situation where thrombectomy times are also taken into account, and that are divided into direct, for example, ER admissions, so that time is 90 minutes, and then transfer, so by the time the patient leaves the door from the other facility to our facility, where is actually the first pass. So in those situations, those times have been identified as well to actually improve the workflow and the possibility of improving coverage. Extra personnel are needed, and again, possibly you have some monetary incentives built in for the hospitals as well. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.